understanding the location of someone's symptoms and signs is crucial. And in the verbal history, I really try to understand not only the current symptoms, but past symptoms. I will harp on this point if I think it's important, because spinal disorders especially have referral patterns and radicular patterns, and understanding where symptoms can go from the spine or where signs can present due to spinal disorders is really key to coming to a root cause diagnosis. When it comes to spinal disorders, there are referral patterns and there are radicular patterns with dermatomes. So when I'm listening or when I'm asking questions, what I'm listening for is where exactly is the distribution of symptoms and possibly signs that the patient has picked up on, like a weakness or an instability. I think of it along this spectrum, starting with unilateral symptoms, and on the left, on the other end of the spectrum is unilateral symptoms on the right. So let's take a simple example of a neck disorder. If there's a neck disorder, it could present with unilateral symptoms into the extremity. So my left arm is on fire, or my left shoulder aches, or my right elbow is pinchy, or I get numbness and tingling into the forearm and hand. So for those patients, I'm obviously asking a ton, is it also on the right? So for patients with symptoms just in one extremity, I would call that a unilateral presentation, and I make sure that that's the case because it informs where I go with the rest of my testing, as I mentioned. Next to that, you could have asymmetrical symptoms. So this applies to the extremity and surrounding the spine itself. So for a neck joint disorder, asymmetrical symptoms, left greater than right, could be, yeah, my left shoulder is the reason I'm here, but I also get some nagging stuff in my right shoulder. It's just not as important. Or I get left neck pain primarily, but some days it's also on the right. For asymmetrical symptoms, I clarify with the patient, what would you call it? 90-10, 80-20. So I'm getting the percentage because, again, it's important for me to understand where to go next. So if it's spinal, just in the neck area, or if it's in the extremity, I'm understanding how much of an asymmetry there is. In the middle, we have symmetrical or bilateral symptoms. So symmetrical meaning it's the left and the right neck equally, or it could be it's just central neck. Bilateral meaning it's into my left upper extremity to my elbow the same amount as it is to my right. So symmetrical or bilateral is right in the center. Now, the same applies to the other side. Asymmetrical, right greater than left, right greater than left neck, and then unilateral just on the right. So this spectrum is important to me because it starts for me to think about, okay, is this a spinal disorder? Probably, especially if there's bilateral extremity symptoms, even if they're asymmetrical. If there's bilateral extremity symptoms, I am thinking spine first as my kind of pecking order of prevalence. I'm also really considering non-musculoskeletal. For example, rheumatoid arthritis that presents in both hands, or diabetic neuropathy that presents in both feet. So a bilateral presentation, I'm thinking spine first, possibly non-musculoskeletal, and then all the other disorders. Think of it this way, tendons in both fingers don't just fail at the same time on both sides of the body, the left and the right fingers. Or ligaments in both knees don't just fail at the same time. Or even weakness, right? If there's no obvious incident, I wouldn't expect your left quad to just get weak the same week that the right one does. Maybe there's a higher source like the spine, or maybe there's a non-musculoskeletal cause. So the reason this is informing what I think is because I'm starting to think, if this is a spinal disorder, where is the lesion? Is the lesion in the center of the spine? Is it on the right side of the spine? Is it the right posterior lateral quadrant, the right anterior lateral quadrant, or the anterior part of the spine? Most lesions of the spine, or let me put it this way, most spinal joint derangements that I find respond by abolishing symptoms and restoring signs to normal, respond to a directional preference or movement in a specific direction into the plane of extension. So that makes me think that I'm attacking the posterior part of the spinal joints. In contrast, those who respond to repeated movements in flexion, I surmise that the problem is in the front of the spinal joint. And again, some of these mechanisms and exact anatomical features of these joint arrangements remains to be discovered, but it's clear to see for many patients, you move them in a specific direction repeatedly with a specific load and a specific amount of force, and their signs and symptoms go away. So for patients where they're presenting just with symmetrical symptoms, equal left and right upper extremities, bilaterally, or equal left and right neck, or equal left and right buttock, for those patients, there's a very high likelihood that the answer is in the sagittal plane of the spine. And due to prevalence and patterns that we see, and likely because of lifestyle factors, the large bulk of those sagittal plane responders are going to be in the extension plane. 90-10 versus extension versus flexion. Now, when we get to the asymmetrical people, it's more on the left or it's more on the right, then I start to think there's more of a likelihood that they're not a sagittal plane responder, that they might need, for example, in the low back, extension with hips off center, which is hitting the posterior lateral quadrant of the low back. Or they might need side glides of the low back, which is just attacking the low back from the lateral compartment, or step standing and flexion. There's different approaches to non-sagittal movements, but the more asymmetrical we get, moving over to unilateral symptoms, the higher the likelihood that we will need a movement of the spine for the spinal disorder to resolve it that is not in the sagittal plane. So something in the frontal plane, something in the transverse plane, or something in a combination of the planes. And that makes sense because we would expect more that central lesions, maybe in the posterior quadrant, that respond to extension, because they're central, they create that referred symptom or that radicular symptoms symmetrically because they're moving backwards and hitting the nerves equally on the left and the right. This is by no means black and white. There are many people with unilateral symptoms who respond to the sagittal plane. But there are fewer people, I would argue, that have symmetrical or bilateral symptoms that respond to non-sagittal plane movements. So this is just a spectrum. It's not a cut and dry rule, but the asymmetry or the symmetry of the symptoms or the unilateral versus bilateral nature of the symptoms starts to make me think, where is the particular lesion in the spine? Which motion will I investigate first? Is there a higher likelihood that there's a sagittal plane motion of the spine to address these symptoms and signs? Or is there a higher likelihood of a non-sagittal motion of the spine being the patient's directional preference that fixes the disorder? I'm almost always starting in the sagittal plane because the prevalence of responding to sagittal plane movements, primarily extension, is so high in the population. But if there's an obvious physical deformity to the side, I'm starting with a non-sagittal plane motion. But for patients that I'm even starting in the sagittal plane, say I'm starting with extension of the low back for just right thigh symptoms, I know that if it's just right thigh symptoms, the likelihood that I will need to go outside the sagittal plane is higher.